Also on the table is a 10% Medi-Cal provider fee cut, which is likely to be delayed because of court activity. Already, California pays about 47% on average of the Medicare rate, which is usually considered to be a lower rate than that paid by commercial insurers for the same type of care. And so it's very likely that physician groups will take this to a court battle, in which case the California courts or the federal Supreme Court could potentially rule that it's a inadequate reimbursement and actually creates too many limitations on physicians. If not, then you may end up with a bunch of physicians who are no longer willing to take Medicaid. And while this isn't the end of the world, one Medicaid rate is not the same across the board. Community health centers get different rates. Inpatient hospitals negotiate rates with the California Medical Assistance Commission each year. But changing the outpatient fee schedule could have pretty significant impacts on outpatient clinics in hospitals, as well as in private physician offices in the community. And there are already well-documented problems with Medicaid beneficiaries not being able to get services through their community and needing to go to public hospitals and county systems for their care, even though they're insured. Also, keep in mind that with the new 1115 waiver, that kind of helps to redesign Medicaid and allow for matching funds to come in to support the indigent population as a bridge to health reform, and also the expansion of Medicaid that should go into effect in 2014. It seems like we're going in the wrong direction a little bit, in that we would be weakening the Medicaid program prior to then growing it in 2014 and getting rid of a bunch of providers because the fee schedule is too low, kind of disenfranchising a population of chronically ill people because they can't go for more than 10 visits, could hurt their health status, could hurt their income, and then giving them coverage in 2014 and dealing with that pent-up demand and worsened health status and chronic disease burden they might face at that point is a serious concern, in my opinion. This is just to, I don't know if any of you are familiar with this idea of the Pareto rule, but it's basically that 20% of things always represent about 80% of cost. So traditionally, we've seen 20% of Medicaid beneficiaries represent 80% of the spending in Medicaid. We have lots of kind of healthier children and moms on Medicaid, but the majority of spending is taken up by the chronically ill population. And so when you're dealing with 10 visit cap and a 6 prescription drug cap and these copays, you can pretty much see who's going to be most impacted by these cuts. It's going to be the chronically ill, those who already spend a lot. And this is some information from the California Healthcare Foundation that basically shows that 1% of the Medicaid beneficiary population represents 14% of those who spend over $100,000 on claims. And that this Pareto rule is really a big issue in healthcare spending in general, in that the majority of folks, 93% of beneficiaries, cost less than $10,000 per year. So it's really, these cuts potentially really target a specific group of people that probably will be most hurt in terms of health status and limitations on their care because of chronic illness, disability, and those types of things. In the same way, you see that the high-cost individuals, those spending over $100,000 or more through Medicaid, are primarily chronically ill. So they have pulmonary conditions like asthma and COPD. They have neurological conditions, mental health conditions, cardiovascular disease. And these are all, of course, conditions that probably can't wait for another 3 years until federal health care reform kicks off and we have a little bit more money into the system potentially, or until the budget situation improves. These are people that will be hurt immediately by potential cuts to prescription drugs that help them manage their diseases, especially if they have comorbidities that fall into multiple situations where they might have cardiovascular disease and asthma and diabetes and a mental health condition where they need drugs to treat each one of them to maintain their health. Other important proposed cuts which will be discussed by the next speaker are focused on reductions in in-home supportive services. So this will really hurt the ability for seniors to stay in the home, in that there will be hour reductions on the hours that are supported by Medicaid, in that certain beneficiaries under IHSS have a maximum of 283 hours of in-home supportive services, and they're proposing an 8.4% cut in addition to the 3.6% cut from last year's budget cycle, and that represents roughly 30 hours in a month of reduced services. And there is concern that this likely decrease in in-home supportive services is going to result in an increase in skilled nursing facility use, which ends up costing far more money for skilled nursing beds than it does for in-home supportive services. So and because IHSS is an optional benefit, it's easier to make a cut there. It's hard to make a cut in skilled nursing because it's not an optional benefit. So you can see where the incentive to cut now, save money in the short term, isn't going to fix things in the long term, because then we may see a spike in skilled nursing facility spending in the future. And as Jean mentioned, next year, if we're facing a $40 billion deficit, there's not going to be any room for error, and we're going to have an even worse situation because of the fact that we're spending even more on skilled nursing potentially. Also, developmental disability services are potentially targeted for cuts, where money would be taken away from the regional centers and service provider reimbursement. There are also SSI and SSP cuts, about a $15 reduction per month, which would take us down to the federal minimum, which is a problem in California, where cost of living tends to be much higher, especially in urban areas. And some work out of UCLA from Steve Wallace has shown that seniors in California are already about $12,000 behind in terms of what it takes to support their rent and lifestyle over what it would cost at the federal level. Another issue I wanted to bring up is this. You can see here that, just to underscore the skilled nursing issues, that community-based long-term care, often for the highest spending population, makes up a lower percentage of their spending. We have lots of people, about 32% of those who spend over $100,000 in Medicaid in a given year are using long-term care facilities and hospital inpatient facilities. So right there you have a large chunk of the high-spend population, and controlling that through community-based long-term care, through in-home supportive services and other home-based services can be very important in saving money in the long run. And so we kind of end up with this counterintuitive cut system because of the fact that it's an optional benefit versus a required benefit under federal law. As Jean mentioned, we have these issues around realignment of state-county services. Some of these changes do make sense. There could be efficiencies grown out of realignment. For example, it's very possible that the governor will be able to take some of the burden off of Department of Social Services staff in terms of enrolling people and making them eligibility determination and enrollment in Medicaid. And that could certainly pay a lot of dividends in 2014, when a much larger portion of the population is likely to be eligible for Medicaid due to the higher federal poverty level guidelines. But there are also concerns that realigning will take away some money from the county government that they need to process Medicaid applications to provide help to the population, while the state is also planning to shift dollars from statewide Prop 63 money, for example, down to counties and put them in charge of certain responsibilities that they may not be used to delivering at all times, and making sure that those counties are efficiently able to provide services under that budget is a little bit risky. In addition, that money is only until 2012, and the plan, according to the governor's published budget proposal, is for the 2012-2013 year that there would be money dedicated to those county level realignment efforts, but we're not sure where they're going to get those dollars. Perhaps there's a magic hat somewhere they will pull it out of. But reapportioning Proposition 63 money to the county temporarily and then saying this $861 million is going to be there in 2012 when you need it, kind of seems like an empty promise at this point, considering the way that the budget is working out. In conclusion, the governor does face this bad situation and significant limits on their ability to be creative under the state budget, just due to the way tax structure is and things like that, as well as the limits put on Medicaid, Healthy Families, and other programs due to federal requirements about maintenance of effort, due to healthcare reform, as well as federal requirements about optional and required benefits under Medicaid. But it could, these cuts could substantially change our ability to successfully transition to this new world of people having, 93% of Californians having access to health insurance. And we should make sure that the Medi-Cal program is brought up to speed with the rest of our system, with the health insurance exchanges, with rate review, rather than being overly or kind of unfunded or defunded to a level at which Medi-Cal is no longer a feasible way to provide care to a substantial portion of the uninsured population. And as I mentioned before, some of these cuts appear to be quite counterintuitive in that they do leave federal matching funds on the table, especially those related to Medicaid, and they increase the demand for more expensive services as a substitute. So getting rid of IHSS may result in higher skilled nursing facility use. Getting rid of over-the-counter drug coverage under Medi-Cal could result in more physicians writing prescriptions for the same drug, or potentially prescribing a more expensive name brand drug because the over-the-counter drug isn't available. So I think we have to be cautious about the way in which we view these cuts and work within the constructs we're dealing with, but also kind of defend some of these, the logic at least behind some of these arguments. Thank you.
Thank you.